And everybody's start off.
Let's start.
Yes, sir. Good evening, everybody. So welcome back to our sessions. So today, I'll be talking about epilepsy and seizures. I mean, this is going to be a basic version of, seizures, the origin of seizures, the history of seizures, epilepsy, and also a common epilepsy syndromes that we come across in a day-to-day basis. And also, very importantly, there are interactive videos as well, and let's go through them in slowly. So I'll do this in two sessions. This is the introduction to seizures and epilepsy, and the next session is also, the continuation of this session will be the proper syndromic identification. So let's start with the basics. So this is one of the picture I try to, give you an advantage of, having all of them. This picture actually has many situations wherein this could be an aura. So in the first picture, if you see on the left, this is called deja vu. So deja vu can actually be a seizure aura in temporal lobe seizure. So deja vu is basically the person feels that whenever the seizure starts, if he feels that he has seen or he has been in this place. For example, there's that I had a patient who was around 18 years and he was robbed at a supermarket. So whenever so that memory has gone into his brain. So whenever he has a seizure, so he has a temporal lobe seizure, epilepsy. So whenever he has a seizure, the aura comes with the same vision of him being in the supermarket being robbed. So that is called deja vu. So deja vu can also sometimes be a seizure aura in temporal lobe seizures. So Gemaivo is another form of a different aura. And the down on the left side, if you see, this is a typical aura what you see in occipital seizures. If you all know that occipital cortex is a visual perception and visual cortex. So if the seizure is originating from occipital lobe, especially there are few syndromes which are called photosensitive occipital lobe epilepsy or childhood occipital onset visual epilepsy. So these are the two entities, and also sometimes neonatal hypoglycemic brain injury (NHBI) can also have occipital onset of seizure. So this typically starts with, geometrical figures and visual hallucinations. So that is typically depicted on the left bottom of this picture. And these are actual pictures which are which are drawn by the patients who had occipital epilepsy. And occipital epilepsy also has some variants of it can also have visual perception issues like micropsia, telopsia. Micropsia is, abnormally the normal object looks very smaller. Sometimes you have macropsia, smaller objects look very larger. In the same way, sometimes the objects can look farther. That is called telopsia, and sometimes the objects actually can look very near. It's called pelopsia. So I had one patient who had occipital lobe epilepsy. He typically says that whenever he's traveling, he sees a car which is very far from him. It appears as if it's very near to him. At hand's distance. So that is pelopsia. So visual perception issues can also be an aura in occipital seizures. So this is just an introduction. Let's discuss this in detail. So I'll just quickly rush through the historic perspective of the epilepsy and the origin of seizures into the current landscape where we are currently and where we have actually begun from, and the basics of seizure. It's very important to understand the difference between seizure and epilepsy and also the classification. It's a uniform classification we have, which is given by ILA, that is International League Against Epilepsy, and few aspects about seizure semiology. So this part of session is going to be the first part of epilepsy syndromes, because if you understand the semiology of various seizures, so that along with the EEG signature, that along with the clinical picture and the age would fit into an epilepsy syndrome per se. So syndromic identification and epilepsy syndrome will be continuation of this session, and also we'll look at a lot of clinical videos as well. So quickly going through, if you see back then, 200 to even 1,000 years back, seizures were thought to be that they didn't even know that it originated from the brain. They thought it was a divine intervention or demonic position. So they used to call it sacred disease in the Greek mythology and also in early medical texts of a lot of Middle Eastern countries. You have the Assyria and Acadia. This is the same countries wherein you have Mediterranean region, wherein a lot of religion. And so to summarize, all of them across the world, different ancient societies actually believed that it is actually a demonic possession. So now you understand why am I putting this slide? Because even it's now 1,000 years after the origin of this demonic possession theory. Even now, even in cities of India, if somebody has a seizure, I have seen educated people putting iron rods and lock iron metals and in the patient's hand. Imagine thinking that this scientific reason for the seizure cessation, which is very sad to say actually, because that is the reason I put this slide, because we have to understand, iron has nothing to do with seizure. So at that time, people believed that it was demonic position. So iron is metal is the one which counteracts the demonic position. So they used to use iron rod, but it doesn't make any sense in the current era. And also few years past in the late 17th century, 1700s, there was this concept of trephination. Trephination is a concept wherein whatever the CNS pathology, trephination was even done in encephalitis. So children or adults with seizures, with encephalitis, they used to do burr holes with, when in a very septic and a very unhygienic way. So you see the picture, this is depicted. They're putting nails inside the brain to relieve the pressure. So initially they would respond because if there's a raised ICT, so that is technically like a bad version of burr hole, which relieves the pressure. But later on, the patient would die because of sepsis and infections. So again, they used to use this for seizures as well. But again, this was debunked a long back. So again, this is a picture again depicting, using of iron rods or objects during seizures stemmed from the historic belief that epilepsy was caused by malevolent spirits and demonic possession. And obviously, this has nothing to do with seizures. And then uh, from the point of Hippocrates, actually the entire understanding of seizures has changed. So that is a major landmark. So this is not only in seizures and epilepsy and neurology, the entire understanding of science changed. So that is what this period was called as a dawn of scientific understanding. So not to undermine what Indian medical literature has, at the same time, Indian medical literature also had Samhita, Charaka Samhita is one of the Indian literature when it actually described convulsions and blackouts and loss of consciousness originated from brain. So it took almost 500 to 700 years to understand that seizures are actually coming from brain. So this is the concept where it was emphasized in this era of Hippocrates. So all the theories of demonic possession, the internal causes, and all that was debunked, and the focus on brain started this time. So this is also the milestones of various anti-seizure medications. So now if a patient has a seizure, we have around 50 to 60 anti-seizure medications on board to choose whatever we want. And this actually originated from single drug in 1850. The first anti-seizure medication was potassium bromide and phenobarbital. So we still use phenobarbital in neonatal group, but after that, major drugs which I would like to emphasize is after potassium bromide, we had primidone and ethosuximide came in 1960s, one of the oldest drugs. And in during our independence time in 1950s, Salthiam was one of the commonest anti-seizure medications, and carbamazepine is one of the oldest in focal epilepsies. Then came benzos in 1970. So benzos, ever since benzos came, it has revolutionized seizures and epilepsy, clobazam, clonazepam. And then the next generation drugs came in 1980. We have vigabatrin, zonisamide, lamotrigine, oxcarbazepine, felbamate, topiramate, levetiracetam came in 90s. And again, in 2000, we have new drugs like steripentrol, lacosamide, eslicarbazepine. And now we are in the era of precision medicine from 2010 to 2025. We have reticobene, perampanel, briverestam, everolimus, and now we have precision medicine, that is drug tailoring according to the gene mutation. So we'll also discuss about that in the coming slides. So ever since next generation sequencing came, so a little bit about the genetics. In 1975, we had Sanger sequencing coming up. So in the 2000s to 2010, next generation sequence or whole exome sequencing came up. In India, it came up somewhere in 2000, after 2015, in that time. So ever since that, the entire understanding of seizures and epilepsy has changed, because we are now understanding seizures better and epilepsy better with all these channelopathies. So this is the era of channel. We are currently in the era of channelopathies. Every genetic epilepsy needs to be identified genetically, and we have a sodium or a potassium channel mutation understanding, and we know the specific drugs also which can be used. So in the current era of sequencing, we are in the second generation sequencing, that is whole exome sequencing, and very, very quickly we're moving to third generation sequencing, that is nanopore sequencing. That would be long read sequencing or whole genome sequencing. So it has already started in India. It's already being done in the city as well. So this is the current situation of all the genetic testing in epilepsies. So this is quickly an overview of all the channelopathies and why is it so important? Because each channelopathy will have a precision drug. For example, if you don't have the exact understanding of Dravet syndrome, you would be using 5 or 6 medications with no use. Because, for example, if you're using 7 medications in Dravet syndrome because of refractory epilepsy, and if you're using 2 sodium channel blockers, they'll actually increase the seizures. So you're giving 2 seizure medications which will increase the seizure and 5 medications to decrease the seizure. Obviously, the child will not be seizure free. So you need to understand the exact pathophysiology. So genetic etiology, you have to target the etiology at any cost because that is the most important thing. You have to go deeper, deeper and try to understand what is exact etiology. And there's no shortcut for epilepsy. I mean, any patient who has epilepsy does not necessarily mean that he has to be started on levetiracetam. That is the most I mean, it doesn't make any sense to start levetiracetam without knowing what the cause is. You don't have answers like what happens next, how long do you give, what if he has seizure, what is the next drug? You have no idea. So you need to go to the root cause and try to identify what is the exact genetic origin if it's genetic epilepsy. So these are various examples. So the first example here on the left, if you see, SLC2A1 is the gene which is responsible for GLUT1 deficiency. It's one of the commonest, it's one of the drugs which are conditions wherein we have precision therapy as ketogenic diet. So ketogenic diet is actually the first line therapy. We don't use any drugs as such. In the moment you start the patient on ketogenic diet, he'll be seizure free. So that is the first line agent in this medication, this particular condition. So other examples here are mentioned here. For example, SCN1A, SCN2A. So if you have sodium channel mutation, then the second thing you do is check this loss of function or gain of function. If it's loss of function, that means the channel is not working. And on top of that, if you give sodium channel blockers, that means the child will have more seizures. So in Dravet syndrome and loss of function, sodium channel mutation, you have to avoid sodium channel blockers. So you need to understand that concept. So there are multiple precision medical medications currently available. We also have potassium channel blockers like mexiletine, flecainide, all that can be used. There are more examples of all the precision medicine. I think this would be out of the scope of this discussion. This itself is a separate seminar. So coming to this slide, again, this slide is very important. Why is it so important to understand the guidelines and the classification that you understand in which are given by International League Against Epilepsy? Because we need to have a common language or a common terminology which are describing the same semiology or the same type of seizure. For example, I'll give you an example. Like there's a syndrome called Douce syndrome. Douce syndrome is basically the patient has myoclonic seizures and atonic drops with continuous drop attacks. So when we don't have a common terminology, some people call it Douce syndrome. Previously, it was called Douce syndrome. Now we use a different terminology called epilepsy with myoclonic atonic seizures. EMAS is a ILA terminology. So when you publish or do a study and you have a randomized control trial, and if you want to do a meta-analysis involving different countries, multinational, multicentric studies, you need to definitely have a common terminology so that you can all have a common understanding and common studies can be done. So it's very important that we use the terminology which is used across the world and that is being done by ILA. So we need to understand the ILA classification. We need to respect the ILA seizure classification. So quickly, there is no shortcut for identifying any epilepsy or any seizures. Do not directly. So if you see on the right side, shortcut is any. So it's very common that even if you have the subtle doubt that it's a seizure, I mean, people don't, hesitate to start levetiracetam on the day one. So that should not be done because any abnormal movement in a child is not a seizure. And most of the time, uh, paroxysmal non-epileptic events are more common in children, especially in the first 2 years. Abnormal movements usually, it does not end up having actually seizure. It can be any abnormal movement which is non-epileptic. So in that levetiracetam, adding a levetiracetam doesn't make any sense. So We need to be methodological. I mean, you have to be systemic. I mean, the original road with any abnormal movement, if you're suspecting, you have to go and take a detailed history of exact origin. The detailed history would include perinatal history, family history. I hope you understand why family history, because a lot of channelopathies are autosomal dominant. Inborn errors of metabolism can have seizures that have autosomal recessive. You have developmental history because most of the inborn errors can have developmental errors. Developmental epileptic encephalopathies, DEE, is genetic epilepsies can also have developmental issues. Past history, because the patients who had febrile seizures are now having afebrile seizures, they'll go into Jeff's plus spectrum of sodium channelopathy. Past history is extremely important. Personal history, drug intake, you need to understand it's genetic or some acquired. Even there's a the common cause of seizure is drug withdrawal. So you also go into any adolescent coming to your clinic with seizures, it could be withdrawal of some drug, it could be marijuana withdrawal, it could be alcohol withdrawal can also cause seizures. So personal history is also important. And along with all this, the most important thing is home videos. Definitely, this is the most crucial point of diagnosing any seizure, because it's very unusual that no seizure it will be seen. The first seizure will never be seen by the doctor, because the first seizure will obviously be witnessed by somebody at home, parents or any relatives. So you need to ask them to take home videos, because home videos are extremely informative. Then, based on this history identification and also the detailed family history, and then you plan rational investigation, because there's no one single formula for epilepsy that any patient with epilepsy you have to do MRI epilepsy protocol. That doesn't end there. You need to rationalize. You don't do all tests in all the patients. So, for example, you don't do genetics in all the patients, because if you find a cause in the MRI, for example, MRI shows neurocysticercosis. What is the point doing genetics? So it should be patient tailored. And start with MRI and EEG. MRI for structural causes, easy to identify what type of seizure is it, where is the origin of the seizure, is there epileptic encephalopathy, is there non-convulsive status. Different kind of information comes from EEG, different kind of information comes from MRI. And then you can go for blood investigations, like for example, fires, febrile infection related epilepsy syndrome. So in that fires, blood investigations like serum interleukin 6, CSF interleukin 6 would be helpful. Blood investigations would be, sometimes autoimmune encephalitis can present with seizures. You need to do the workup for that blood as well as CSF. And if all the structural causes are ruled out, acquired causes are ruled out, demyelination is ruled out, then you're thinking that it's genetic, then you go for whole exome sequencing or next generation sequencing. So you need to tailor your investigations based on the clinical situation. So that is the whole point of rational investigations. It's not just a simple list. And then try to understand what is the exact etiology and then plan for treatment. So what are the clues here? So this again picture, we are in the current era of technology. Most of the seizures, we all know that both parents and children are now into gadgets. There's a lot of screen time, and most of the time, the child's lovely moments like developmental milestones, all of them are captured for whatever it is, Instagram, Facebook, whatever it is. So most of the time, it happens that the parents are able to capture the videos of the seizures. So make use of the home videos from the smartphones. And also we use special equipment like home videos of home EEG monitoring. And so this is the left picture is basically the first one is actually a home EEG. So this patient has epilepsy. So he doesn't have to come to the epilepsy unit, admit for 4 or 5 days, put on a camera and then see whether he's having epilepsy or not. So this is another technique wherein he has a home EEG machine attached and it's a video EEG monitoring going on. The same thing can be done in the hospital as well. And sometimes we also have some seizures and epilepsies wherein you have night seizures. So that's very easy to capture on home videos in night camera. The fourth picture here in the bottom right is actually a night camera. This is a patient with nocturnal frontal lobe epilepsy who has violent seizures at night. Parents often miss, parents are disturbed, the parents don't sleep all night because the child may seize. So this camera at night cameras would be would be useful in that case. So we can use the various uh, gadgets and modalities to diagnose. So quickly about the definition, seizure is a sudden temporary disruption of normal brain function caused by abnormal excessive synchronous neural activity. Do understand here, which can lead to changes in behavior, movements, feeling, or level of consciousness. So which can lead to. So remember, any seizure, sometimes seizure cannot have any movement also. So seizure, that's still a seizure. It could be an electrical seizure. So if you connect to an EEG, you will see an epileptiform discharges. That's still a seizure. You don't have any movement. So that is called behavioral arrest or motor arrest. Also very important. So I think we all know this, how to differentiate seizures and epilepsy. Seizure is just a single entity that we are describing one event, but epilepsy is defined. We'll see the definition in the coming slides. So this is the most important slide here. I think everybody needs to understand what is the exact classification of the epilepsy. So IL has given a clear operational and a practical definition for epilepsy. So any two unprovoked seizures occurring in more than 24 hours apart. For example, uh, uh, if one child had a seizure today and in the same day he had another seizure, it doesn't technically fall into the definition of epilepsy. So if he has two unprovoked seizure, unprovoked in the sense we have ruled out all the acute symptomatic seizures. Like, there's no fever, there's hypocalcemia, hyponatremia, there's no dyselectrolytemia, drug withdrawal, all that has been ruled out. So then you call it unprovoked seizure. When you have two such episodes, 24 hours apart, then will be defining the epilepsy. Or so this the second criteria, just try to understand why is this put forth. For example, if one child comes to you with one's first episode of seizure, you can't tell the parents that no, your child still has the first episode, we have to wait for the second episode. That can sometimes be devastating. Who knows, the second episode could be status epilepticus. So the parents are also not convinced, and it is also not rational. So if you have one episode of unprovoked seizure, then you have to evaluate. So the evaluation would be family history, it could be EEG, it could be MRI, it could be genetics. So if you have one unprovoked seizure and you have other risk factors which tell you that there is a chance of recurrence again. I'll give you an example. So for example, one child has come to your OPD with first episode of seizure at 3 years of age, and you explain the parents that this is the first episode we have to evaluate. And MRI showed actually periventricular leukomalacia, and this child had perinatal insult. So when there is perinatal insult, when there is MRI finding, so this child will very likely have a seizure in the coming days. So this MRI finding of periventricular leukomalacia, white gliosis, will actually increase the risk. So if the risk is more than at least 60%, then you can actually include that also in the epilepsy. And the third criteria, if the child directly falls into the criteria of epilepsy syndrome, then you don't have to wait for any second episode. I'll give you another example for the third criteria. You see a child coming to with epileptic spasms. So you don't tell the parents that we have to wait for another episode to come. No. If there is one cluster of epileptic spasms, immediately call the patient. You have to do an EEG. If the EEG is showing hypsarrhythmia, if the child has developmental arrest, it is fitting into the criteria of epilepsy syndrome. So they don't have to wait for another cluster, another day, another. So they directly goes into the definition of epilepsy. So these are the three criteria which are given by ILA. So this must be understood and clear. So common causes, I won't go into the details because we have already discussed common causes. In short, I would say it could be infectious, inflammation, metabolic, structural, environmental. Infectious, encephalitis syndrome, encephalitis, demyelination, meningitis, neurocysticercosis, tuberculosis are very common. Inflammatory, these are all the celiac, Hashimoto's are very common in adult, but don't put them in the differential diagnosis of children first. In inflammatory, in children, you have to think about ADEM is the first choice. Demyelinations are very important neuroinflammatory disorders which cause seizures. And even fires also comes under inflammatory here. So coming to metabolic, again, hepatic failure, again, these are in adult more common. In children, we would think of inborn errors of metabolism as the first cause of metabolic causes. Structural, you have neurocysticercosis, cerebral venous malformations, any surgical causes like hydrocephalus, traumatic brain injury, or brain tumors, or any ICSOLs, that should be considered in structural. Coming to environmental and toxic would be drug withdrawal. Some drug ingestion can also cause seizures. And the most important one, and I think in children you have to remember camphor ingestion or camphor inhalation. Even the subtlest amount of camphor, even the smell of camphor, even some children, even sitting in the puja room, also they can even when they even have one lick of camphor, they can have a seizure. So all this will come into toxic and environmental. So these are like provoked cause acute symptomatic seizures. You need to rule out all these before you label the patient epilepsy. So here you have to do electrolyte, calcium, sodium, potassium, rule out infection, get a CBC, try to identify if there's an infection, do a CSF if you're thinking there is CNS infection, do an MRI if there's an acute, I mean, you can see an ICSOL, neurocysticercosis, something like that. Or if you see brain tumor itself, glioma can also present with seizures. So ruling out all this, and also toxic. Don't forget adolescent boys, girls coming with history of something at school happening. So all that you have to ask about the drug history. Sometimes you may have to ask the peers, friends, parents may not know. All that needs to be considered. The etiology is slightly different in neonatal. In neonatal onset epilepsies, you start thinking about perinatal asphyxia. I mean, after ruling out acute symptomatic seizures, acute symptomatic seizures, you have hypocalcemia, natremia, magnesium, and hypoglycemia. These are the commonest transient cause of metabolic derangements in neonates. After this, you need to think of metabolic causes, that is, inborn errors of metabolism, maple syrup urine disease, organic acidemias. The baby will be absolutely normal, normal perinatal transition, cried immediately after birth. The child baby is shifted to the mother side, started on feeds. On day 4, the child baby has seizures. So this is typical history what you see in inborn errors of metabolism. And they also have encephalopathy, drowsiness. Then you do workup for that, ABG, acidosis, hyperammonemia, hypoglycemia, urine for ketones. You have to go in that direction to try to find out what is the exact inborn error of metabolism, get GCMS, TMS, get genetics, and try to identify what exactly is the cause and treat them. So the etiology in neonatal age group is different from children and also in adults. So go in that order. This algorithm would be different in different age groups. So I won't go into details. Is prevalence of drug-resistant epilepsy is very important, because if you don't identify exactly what is the type of epilepsy, obviously the drug resistance will improve, it will increase. But what is drug resistance actually, Jay? So we'll also discuss about what is drug resistance. So drug resistance is basically appropriately chosen. See, for example, if I have a child with epileptic spasms, if I start the child on levetiracetam and carbamazepine, and you say that I have used two medications and it's drug refractory, no. So definition clearly says that you have to choose the right drug for the epilepsy at right dose. And if you have used two such drugs at right dose and the right choice and right duration, after that, if you see that the epilepsy is still refractory, then you call it drug-resistant epilepsy. So, for example, I have a patient with epileptic spasms. I have started the patient on steroids and also vigabatrin, and still the child is not seizure-free. Then I would call it drug-resistant epilepsy. So, the drug resistance also depends on what type of drugs you choose. So, coming to so this is the proper part of the presentation. This is need to understand this, because lot of this has changed in the last few years. So 2015, 2020, we had a lot of modifications happening from International League of Epilepsy. So here, uh, the re- uh, the new classification was given in 2017. So here we don't try to understand. I think it's very important, even in the adults also. We don't use the terms like partial onset epilepsy. We don't use grand mal epilepsy. We don't use petite mal epilepsy. All these are absolutely removed. I mean, you should not use it, because you can't use this in any article, because it won't be automatically taken in the meta-analysis of any studies, and nobody uses that terms anymore. Grand mal seizure is not used anywhere. So partial onset seizures are replaced by focal onset. So why is it important? A lot of people may ask, what is a big deal? I mean, partial, focal, it means the same. No, actually, the ILA is trying to identify not the semiology, it focuses on the onset. For example, if a child has neurocystic psychosis or ICSOL on the left temporal lobe, so initially when the child has seizure, he'll have head version to the opposite side or movement on the one side, and later on it'll become bilateral tonic-clonic. So whatever is the later doesn't matter, but what is the onset matters, because we need to identify based on that. For example, if I have a patient with focal onset, I'll definitely ask them to get MRI ASAP. On contrary, when the child has generalized clonic seizures with fever, I would think it is generalized. In a setup of fever, I would think it's febrile seizures. Or else a child with 9 years old female patient with early myoclonic jerks, early morning jerks, and later on has a generalized clonic seizure, I would wait for MRI, because I know it's a generalized seizure. I'm not thinking focal. So it's very important to know what type of seizure is it, focal onset or generalized onset. A third group is extremely important, unknown onset. When you don't know the onset, don't commit to focal or generalized, because your workup depends on that. Most of the times, what happens is basically the parents directly won't witness the onset of the seizure. So most often happens that parents are in some other room, child is in his own room playing, and suddenly the parents will hear a noise and they'll go into the bedroom, see the middle of the seizure. They don't see the onset of the seizure. So in that case, specifically asked, did you see the onset? Or by the time did you go, the child was already seizing. So by the time they go and the child is already seizing, it is not the onset. So the onset will be unknown onset. So that is also very important, because when you have unknown onset, try to evaluate more, because it could be focal or generalized. So once you label it focal onset, then next would be aware or impaired awareness, focal aware seizure or focal unaware seizure. An example here, for example, somebody who has temporal lobe epilepsy or medial temporal lobe sclerosis. So temporal lobe is very important to understand, because temporal lobe, there is the seizure is originating from temporal lobe. It is not very close to the motor cortex. So when the seizure starts, he does not have motor movements. He'll just have behavioral arrest or motor arrest. So whatever he's doing, for example, he's playing something, he'll just stop doing it. So that's called behavioral arrest or motor arrest. So try to understand, any child who comes with blank staring spell is not absence seizure. That's the commonest mistake people do. Any blank spell, absence. No. Absence seizure is only said when there's behavioral arrest with an EEG correlate of 3 hertz and spike. So without that, you never call an absence seizure. So if you are labeling a patient with absence seizure without doing an EEG, that means it's very wrong. So you describe the semiology, what is happening. So the child had behavioral arrest, or whatever he's doing, it stopped. Motor arrest is the term which is used. So that is a focal onset seizure, focal onset impaired awareness. So during, sometimes what happens is that I had a patient recently with neurocysticercosis who had facial twitching, but he was completely conscious. He knows what was happening. He described the entire event. He said, when the seizures, when it was started, he knew that something was going to happen. He had extreme fear. He had abdominal raising sensation, and then his left side of the face started twitching. He explained it in extreme detail, and it was also video captured by one of his parents. So it matched. So he remembers everything. So that is focal aware seizure. So that can also happen, because awareness is impaired when it spread to other areas of the brain of consciousness. Then only your awareness is gone. Before that, you can have focal aware seizure. So focal onset, try to ask it is aware or impaired awareness. And then coming to motor or non-motor. As I said, temporal lobe seizures initially can be non-motor. They'll only have behavioral arrest and automatisms or autonomic manifestations like sweating, cyanosis, etc. But they'll not have tonic-clonic movements or any sort. So that is focal non-motor seizure. And sometimes the focal seizure can rapidly spread into the motor cortex. You can have motor seizures, focal motor seizures. And then if it spreads to the other part of the brain rapidly, electrical activity can start at one area and spread to another area and spread to the whole brain. Focal onset, then later spreading to the entire brain. That's called focal to bilateral tonic-clonic. If you remember previously, this was termed as focal onset with secondary generalization. Secondary generalization term has been removed now. We don't use the term now. We use the term focal to bilateral tonic-clonic. All right. So that is focal onset. Generalized onset, again, generalized onset, in all type of generalized onset, you will not have awareness intact. Obviously, the awareness will go. There will be loss of consciousness. And generalized onset also, you have motor and non-motor. So very important to understand, generalized onset with non-motor, no motor movements, blank episode, behavioral errors with generalized onset. That goes into the criteria of absence seizure. So if the child is just blank, to say it's generalized or focal, you need to do MRI and EEG. So before that, you can't label absence seizure. So when you don't know exact the onset, you can just label it unknown onset. Again, it could be motor, it could be non-motor. So after you try to understand what type of seizure is it focal, is it generalized or unknown? If it's focal, it's non-motor or motor. If it's generalized, non-motor or motor, unknown, motor or non-motor. After describing that, then try to put it in the epilepsy syndrome classification. For example, focal epilepsy, generalized epilepsy, or unknown epilepsy. Or also see if that particular type of seizure is falling into some epilepsy syndrome. For example, I'll take an example here. The child had motor arrest. I did an EEG. I got 3 hertz spike. So it's a generalized seizure. It's a generalized epilepsy. It is directly fitting into the epilepsy syndrome classification of juvenile absence epilepsy. So that is how you go. Also, write on the paper comorbidities. If the patient has hyperactivity, if the patient has autism spectrum disorder, if the patient has underlying genetic disorder, all that needs to be described as well. That is called comorbidities. And the most important thing, your final diagnosis also should include etiology. So I know that juvenile absence epilepsy is genetic or unknown. I'll put it in the unknown criteria. Okay. I'll take another example. I had a child with right focal epilepsy and EPCs. EPC stand for epilepsia partialis continua. So continuous focal epilepsy since last 1 day. So that is focal seizures. I'll put that in the focal epilepsy. I did an MRI. MRI showed right-sided hemispheric atrophy and white matter. I mean, there is hyperintensities. That falls into the definition of Rasmussen's encephalitis. The same findings were seen on EEG with lateralized epileptiform discharges. So now I know the syndrome classification is Rasmussen. Now I know Rasmussen syndrome is immune mediated. So I'll put the etiology as immune mediated. So your final diagnosis should have epilepsy type, epilepsy syndrome, etiology, and comorbidities. I hope you understand. This is the whole framework which is given by ILA. So this is the detailed classification of ILA 2017. So I've already discussed focal generalized onset. This is a detail. So in motor onset, you have tonic, we have clonic. We also see, just see this. We already know tonic, we know clonic. There is atonic, there is epileptic spasms, there is hyperkinetic movements, there's myoclonic and automatisms. See, I'll give you an example of automatism is a pill rolling automatism. Sometimes, during the seizure, the child, touches his nose, he cleans his nose swipe, face swipe, touching his lips, and pill rolling automatism. These are some of the examples of automatisms. And we'll look at the various semiologies of atonic, clonic, epileptic spasms in detail in the coming videos. Non-motor, as I said, they use the term behavioral arrest. Or sometimes you only have emotional changes or sensory changes. So this is all common to the non-motor arrest. Non-motor onset, just remember behavioral arrest, typically seen in temporal lobe seizures. And as I said, a focal with secondary generalization term is removed. Now we use the term focal to bilateral tonic-clonic. In the generalized onset, motor, you have tonic, clonic, clonic, tonic, myoclonic, atonic, epileptic spasms. Remember, epileptic spasms will come in both focal and generalized. The most common type of epileptic spasm is generalized. Sometimes in conditions like hemimegalencephaly, there is epileptic spasms only on one side. That is called, asymmetric epileptic spasms. They also have something called hemihypsarrhythmia. So epileptic spasms can be both focal and generalized. And unknown, again, I've discussed it could be tonic, clonic, non-motor, the same thing is there. So these are all the changes. I've already discussed this. The term partial has been replaced by focal, and seizures of unknown onset may have features which still not classified. You can just say unknown onset. And the terms dyscognitive, simple partial, complex partial, psychic seizures, all that are not used. A commonest old time neurologists use this term called psychic seizure. Doesn't make any sense. No, it has been completely removed from the classification. New focal seizure types like automatisms, autonomic, behavioral arrest, cognitive, emotional, hyperkinetic, sensory. These are the newer terms which are used. And then new seizures classification semiology is also new. I'll discuss this in the future slides. Island myoclonia, myoclonic absonces, myoclonic atonic. So there are various syndromes named on this. We'll discuss this in the coming slides. So this is again quickly generalized onset. You have multiple foci in the brain, so you don't know where is it originating from. It's the epileptic discharges have spread everywhere. So the child is seizing with all four limbs. So it's a generalized seizure. Focal seizure, there's only focus on the one side. So why is it so important to know this? Focal seizure, I would think of an MRI as soon as possible because even if you start the patient on five anti-seizure medications, if there is a neurocysticercosis sitting in the brain, obviously they won't stop seizing. You have to treat the neurocysticercosis or tuberculoma. So quickly, this slide is again crowdy. Sir, is it fine? The speed is fine. I have to slow down. I'll just see the chat. If
I think you can continue.
okay, okay, sir. Yeah. So, in the phases of seizure, always try to understand the. We only tend to ask how was the seizure, झटका कैसे हुआ है, tonic-clonic movement हुआ है, बस that's it. So we only talk about the ictus. Ictus is the actual seizure episode, tonic-clonic or only tonic or behavioralist. We don't focus on what is happening before. That is most important to ask for. So remember there are various stages of seizure. Even before, I had a patient who had focal cortical dysplasia. He knows in the morning only. For example, if he's going to have seizure in the evening or night, he knows that no, I may have a seizure today, and he does not go to the school, but he does not say to the father that no, I'm going to have a seizure. But he knows he has an intuition. But actually, that's not intuition. That's actually a prodromal phase. That is different from aura. Actually, aura is right in front of seizure, right? For example, if the child is seizing now, exactly like few seconds or few minutes before the seizure is aura. Aura will have visual, auditory, epigastric raising sensation, visual aura in occipital seizures, auditory aura in temporal lobe seizures, olfactory aura in frontal lobe seizures, autonomic aura like sweating, cyanosis in temporal lobe seizures. That is aura. An aura will be immediately followed by the seizure. But prodrome is long before the seizure is going to start. Like some amount of discharges, some adult patients and adolescent patients are smart enough to understand there's something going to happen. All right. And also remember trigger. Trigger is extremely important. Ask the parent specifically. Was there any trigger that day? For example, if a patient seizes only when she goes into the sunlight, wakes up early in the morning, opens the curtain for a bright sunshine, and she has a seizure, myoclonic jerk. So that is typically in juvenile myoclonic epilepsy. Early morning seizures. And apart from juvenile myoclonic epilepsy, there are other photosensitive epilepsies. There's a huge topic of photosensitive epilepsies. I won't go into the details. So photic stimulation is very important. Also, not only sunlight, also ask for triggering lights. For example, the patient has gone to a movie which has uh, disco lights or some very flickering lights in the movie, and that can also trigger seizure. Early morning, very important. Epileptic spasms on awakening is very important. Whenever child sleeps and baby wakes up, they'll have clusters of spasms, typically in epileptic spasms and West syndrome. Early morning seizures are also common in juvenile myoclonic epilepsy. On awakening, epileptic spasms. Sleep seizures extremely important. There's a different whole topic of sleep seizures. What are the epilepsy syndromes which have sleep seizures? But classical examples would include BETS, benign epilepsy with centrotemporal spikes. Now that term has been changed to SELECTS, self-limited epilepsy with centrotemporal spikes. It was previously called as Rolandic epilepsy. Apart from this, you have other sleep seizures like nocturnal frontal lobe epilepsy. Hot showers, a very characteristic feature of sodium channelopathy and Dravet syndrome. Whenever the child has hot showers, they'll have seizure. And also, same category, Dravet syndrome are triggered by any vaccine or any fever-induced seizure. Noise-induced seizure is a characteristic feature of progressive myoclonic epilepsy. Action-induced seizure is also a very characteristic feature of progressive myoclonic epilepsy. So PME is another rare entity, and I won't go into the details, a different topic altogether. Can anybody guess what is catamenial seizures? As the name itself says, menstrual cycle can actually trigger a seizure, a very common condition. Any cause, for example, be it structural epilepsy, be it a neonatal hypoglycemic brain injury, any gliosis or any genetic epilepsies, when the child has menarche and during the menstrual cycle, whenever there's bleeding, then there's a very likelihood chance that there can be a seizure which can be triggered. This can be explained because of the hormonal disturbances which can have, you know, effect on the epilepsy itself. So all this trigger needs to be asked, then ask for the prodromal phase. Aura, specifically what kind of aura? If the child is more than 7 years, definitely he'll be able to tell what happens before that. So ask them what exactly happens. What do you see? How do you feel? What do you understand before? Most of the times, school-going children also are smart enough. They know that they're going to have a seizure. They'll sit down because they understand that, if they stand, they'll fall and they'll have an injury. So eventually patients will also know how to adapt with the seizure. So that aura actually helps with that. And also understand what is post-ictal phase. Sometimes it can be important. Post-ictal phase uh, is very important to know whether it was a seizure or not. If it's a non-epileptic event, there won't be post-ictal phase. It's a true seizure, then you have a post-ictal phase lasting from somewhere between 15 minutes to even 2 hours also. So in post-ictal phase, once the child wakes up, headache, post-ictal headache is a very, very good sign to differentiate non-epileptic from epileptic. A non-epileptic event, a psychogenic event, the child wakes up, he'll be normal. But if the child really had a seizure, he'll have a very bad headache. That's called post-ictal headache. Sometimes you have post-ictal confusion, post-ictal drowsiness, and some rare types you have focal seizures continuing for a long time. You can have Todd's paresis. Todd's paresis is basically one side where the seizure originated in the brain. So opposite side, the child will have paralysis. Or the child, the side where he had focal seizures or tonic-clonic movement, that side will go into paralysis paralysis for some time. So that's called Todd paresis. So this is the whole event of seizure. Everything before starting a seizure and after asking, so this entirely needs to be asked in the history, because the video recording of the event only will give the ictus. Everything before and after you need to actually dig in. So this is one slide to understand non-epileptic from epileptic events. So you need to know red flags to identify it's a true seizure or not. So it will be very devastating that the child comes to you with a true seizure and you just mislabel them as non-epileptic event. You say vice versa can both can happen. Non-epileptic events sometimes are overtreated and sometimes a true seizure can be undermined, saying that it's non-epileptic event. So both of them should be avoided because both of them have devastating consequences. So whenever you have a tongue bite, especially lethal tongue bite or major injuries, like the child had a seizure, he had a laceration in his head, it's very unlikely that he's doing it purposefully or he's doing it non-epileptic event. It is a less chance that it will happen. So major injury, head laceration, fracture, tongue bite are in favoring of true seizure. Post-ictal drowsiness, post-ictal headache, confusion, very important for understanding it's a seizure. Always remember, any child who's trying to, it's a very simple clue. Whenever the eyes are closed, it's never a seizure. Most type of seizures, 99% of seizures, the eyes will be open. So whenever he's closing the eye, that means it's non-epileptic. So this is a very important clue. And obviously, sleep seizure cannot be, mimicked. So sleep seizure is always a true seizure. And you also have some sleep movements, like it's called nocturnal other movements in sleep. So somnambulism, all that needs to be sometimes differentiated from sleep seizure. Seizure versus pseudo seizure, I won't go into the details. True seizures will be, less than 10 minutes unless and until status. This paroxysmal non-epileptic events, psychogenic events go on for hours together. Aura is clearly, aura is clearly described in non-epileptic events, but sometimes in true seizures, the aura is described, but it's often blurred. They won't tell you the exact description key. They'll tell you some clues because the seizure is going to start. They'll not remember that. And the recollection of the entire event is usually very blurred to complete blanked out because the child won't remember. That's also a reflection of true seizure. And every time the child will have the same event. If the child had a focal epilepsy with a neurocystic psychosis left, they'll all always have the same type of semiology. Facial twitching, seizure starting from the right side and it going to bilateral tonic clonic. You think that, if the child is trying to fake, why will he do the same semiology every time? So with the non-epileptic, even every time he'll have different movements. And also remember head fixed to one side. This head version is a very good sign of a seizure. Ictal urination and defecation is a favoring of seizure. Autonomic changes like tachycardia, sweating, especially useful in PICU setting and NICU. When the child is having a seizure, just look at the monitor. This tachycardia, there's sweating, there's increased heart rate and respiratory rate, and goes in more favor of seizure. Pseudo seizure duration is very variable. Sometimes can last for hours. Aura description is factual description. Semiologies keep changing. Head side to side movement. There'll be asynchronous movements, both hands and legs, like moving randomly. That is all pseudo seizure. So I've discussed this. Overdiagnosing a seizure will have unnecessary medications for 2 years. Levetrestam is commonly used, thinking that it doesn't have side effects, but levetrestam does has a lot of side effects, like aggression and violent behavior. And phenobarbital in neonatal age group very commonly described to be in India that we keep giving phenobarbital for a longer time. It is known to cause cognitive decline according to many studies. And all other anti-seizure medications, every drug has a side effect. When you don't have an indication, don't give them. And a deadly side effect like lamotrigine, oxcarbazepine, Steven-Johnson syndrome is a deadly complication. You can have medical legal issues as well. Weight gain is seen in valproate and other drugs. Ataxia can be seen with phenytoin, hepatotoxicity with valproate. I won't go into the details again. Underdiagnosing here. See, underdiagnosing can have there's a child who has come to with seizures. You say that it's non-epileptic just because she's an adolescent girl. Say it's non-epileptic, just send the patient away. There could be a possibility that the child can come with a bigger seizure in status and get admitted to the ICU. So then it doesn't make sense. We have to evaluate even it's an adolescent. So don't just go with one parameter that is an adolescent female. So next seizure, the child can have SUDEP also, aspiration and die. And like some devastating seizures like epileptic spasms, if they are misdiagnosed as colic. Epileptic spasms are commonly misdiagnosed as benign myoclonus, benign sleep myoclonus, colic, GERD, and they don't treat it. And months together, they go and they'll have developmental arrest and regression. And also, like, constant seizures happening in the school, sometimes the child can also be depressed or underconfidence because they're mocked in the school. So I've discussed this. I won't go into the details, psychogenic and epileptic seizure. And you need to differentiate seizure and syncope also. A syncope is another common entity. One point I would like to highlight is that syncope, I think we all know how to identify syncope because you have a prodrome here. A prodrome, you have the exact situation, you have the timing. Syncope doesn't happen all of a sudden. So you have some environment. For example, the child is in the assembly, he's in the sunlight, he has not had breakfast, there's dehydration. All that together will cause some event wherein he loses consciousness. Remember here, in syncope also, once the child collapses, in vasovagal syncope because of the hypoxia, sometimes you can have jerks in the end of the period. For example, loss of consciousness happens first, and then later on, at the end of the 1 minute or 2 minutes, you can have some jerking. So that doesn't necessarily mean it's seizure, but that myoclonic jerking is because of the hypoxia. That hypoxia is because of vasovagal syncope. So remember all these points that syncope has to have some sort of a situation, like prolonged standing, always happening when he's standing, always happening when he's playing. He had not had enough hydration. So if syncope, you don't have to do anything. Sometimes you may have to do EEG to rule out seizure, and then tell the parents. It could be we have to rule out cardiac also. We have to do 2D echo, and then understand and focus on frequent feeding, frequent hydration, constant leg movements and calf muscle contractions, so that the peripheral pumps the blood up, so they have vasovagal syncope chances being less. All that needs to be discussed with the parents, and you have to differentiate between seizure and syncope. So coming to the proper seizure semiology, the first case scenario is this occipital seizures. So this is a case with
Dr. Jayanth, can we take cases in the next session?
yeah,
Will it
sir.
be useful? Yeah.
Yeah, yes, sir. No problem.
So with this, we will conclude this session for